That first SARS virus is well known because it did cause severe illnesses. It carried a fairly high mortality rate. Um, and because of that, many persons did not want, nobody wants to know that we're having another outbreak of the same thing after it had been well known before. What was different is that original SARS virus, SARS-CoV, was known to exist in the animal population, in bats and civets and some other animals prior to it making an appearance in the human population. But this SARS-CoV-2 is very similar in structure, except that it seemed to be far more infectious than the original SARS virus. Both of them are very infectious, but this one was one of the most infectious illnesses. So, in terms of the illness, it's important for people to understand that it did not take long for this virus to begin to spread throughout the city and around the world. If you compare the traffic, the air traffic in and out of China now with what obtained 20 years ago in 2002, you'll recognize that there's far more movement of people in 2019 and 2020 than there was 2 decades earlier. And so it was very easy. There are Vincentian businessmen who make 2 or 3 trips per year to mainland China. And you might be surprised at the number of persons who travel back and forth from China to St. Vincent. And you could imagine for the rest of the world, because China has become such an important economic powerhouse, especially with regards to manufacturing and supplying of goods and services. Now, the illness became a public health concern globally when it was recognized in multiple different countries around the Southeast Asian region initially, and then all the way up to Europe and North America. And of course, not long after that, it was declared as a pandemic because it had touched so many countries around the world. The illness itself generally comes on with flu-like symptoms: fever, headaches, body aches, notably for some people, loss of appetite, loss of smell and taste, and a cough, usually a dry cough to begin with, which may become a wet cough later on. Many persons, when they feel like they're getting better and the fever begins to subside, a profound weakness takes them, and then they become short of breath. They have difficulty moving around, and they may develop one of the complications. So, what I really want to get at is the fact that many persons with COVID-19 may begin with the flu-like illness, and then it was noted that a lot of people, after overcoming the flu-like illness, began to develop other symptoms, including blood clotting syndromes, strokes, heart attacks. There were other um, noticeable symptoms associated with COVID-19, where blood vessels in multiple organs became clogged. And so maybe the main mode of causing illness and death for COVID-19 is a coagulopathy. In other words, the presence of the virus in the body seems to trigger an abnormal blood clotting cascade throughout the body, and you can have damage, in some cases irreparable, to some organs. Um, Eye vision problems have been reported, kidney problems, respiratory problems. So the illness itself is well known, well documented, and just about a week and some ago, I was able to speak to a relative of a 21-year-old young man who was admitted to hospital with after testing positive for COVID-19. He suffered a stroke. He's not able to speak. He is not able to move his limbs on one side. Um, he's 21. He was unvaccinated. It is unusual to see this sort of stroke in young people, but it's becoming more and more common since the onset of or the arrival of COVID-19 in the general population. So many persons have been affected by COVID-19. We hear a lot about deaths, but deaths are not the only concern that a person should have about COVID-19 as an illness. We've also noticed that many persons, after having COVID-19 pneumonia, end up with a fibrotic reaction where there is stiffening of the lungs, and therefore the person has some restriction with breathing. We call it scarring of the lungs. And this is one of the long-term effects of COVID-19. Many persons have recovered from the acute illness, but found that they have some irregularities of their heartbeat, or perhaps they've noticed that they get very tired easily with exertion. And you could think about people who have a career in athletics or so who are have a long-term impact of this illness, changing the course of their life in the future. So please, I want us to understand that COVID-19 is not just about getting a flu, and if you die, you die, and if you live, you're back to normal. There is a large burden of disease associated with COVID-19 as an illness. In 2019, in November, when the virus was first discovered, the information regarding the structure of the virus, the genetic makeup of the virus, was transmitted globally. There is a network that allows this information to be passed to all cooperating countries, and so that everybody doesn't have to go through the same work of identifying the specific genetic material. However, it not only was the similarity between the SARS-CoV virus from 2002 to 2004 identified, but the fact that there was a potential for this illness to be addressed by use of vaccination or immunization. Many persons did not know that by the end of January, most of the entities who had the ability to develop vaccines or the technology present, many of them had already indicated that they were working on vaccine designs. So, because of the structure of the virus having spike proteins, which your immune system would automatically latch onto, it was postulated then, or a theory was made that those should be the focus of vaccine development. And therefore, the question is whether or not this would be an effective way of controlling this illness. Well, we've seen what happened in 2000 and in 2020. We saw the outbreaks in Italy. We saw the outbreaks in New York. I have colleagues in the United States who told me they've never seen anything like this, where people are lying on a trolley in a parking lot or in a hallway, waiting for an opportunity to get into hospital just so that they could have some kind of treatment, hoping that they would survive this illness, having difficulty breathing and so on. And the having to live through that situation is quite different from what we would have seen on TV. Remember that the TV crews could not get into the spaces where healthcare workers were operating, and very often could not really bring the pain and the suffering that's associated with massive outbreaks. But we know, because it has been not just in the United States, but neighboring countries like Trinidad, where the healthcare system at one time appeared to be becoming overwhelmed by cases, and also in Jamaica. In fact, on the weekend of when we had two holidays granted, the 6th and 7th of September, our colleagues in Jamaica indicated that there were patients who were dying because of COVID, but not from COVID. In other words, the country had run out of oxygen because the demand for oxygen in COVID patients was so high. And patients who required simple, life-saving surgery like obstetric surgery, women who came in to deliver babies and ended up becoming complicated. Some of them actually died in childbirth because there was no access to the definite and specific care that they needed because of the shortage of resources. So this illness has the potential to cause real serious problems. So I want to go back a little bit to how the healthcare system, how the medical and scientific community responded to this illness. Because what was seen in Jamaica there, or in Italy, or in New York, or even, I mean, this illness almost brought the United States, the big cities, to their knees, because you had New York City putting out a cry for help to other cities for workers to come in, for resources, for more for more ventilators and other supplies that they were running out of. You heard stories about big businessmen sending their personal jets to China to pick up PPE for healthcare workers just to get back to the United States. And many of us have heard these things, but it didn't hit home because we were having sunny skies and good weather here in the Caribbean for most of that time. In fact, 2020 was a wonderful year for some people because we had a strong political campaign and elections in that year. Maybe some people were distracted by all that. But there was a lot going on in the medical and scientific community with regards to COVID-19. What I want us to think about is, what is the responsibility of those who are charged with looking out for the sick and dying among us. We look for solutions. I think that companies, hospitals, whether private or publicly funded, um, drug companies that produce drugs or medicines, the mission is really to find solutions. And people may ask the question about whether these companies should be able to turn a profit. I mean, who goes into business without the intention of turning a profit? But it doesn't mean that what you're doing necessarily has to be, nefarious or some kind of illegal activity. A person who is a professional plumber had professional training, and they put together an organization that's able to respond to plumbing needs in a record time, and you can charge premium for that service because you're providing a service and you do expect some remuneration. The thing with drug companies and other producers of medicines and so on is that they don't always win. And so when a company works on a product, there's no guarantee from the front, from the beginning, when they start research and development, that this medicine will make it through to the market. And I want us to understand that for people who think that this was, just a whole setup, um, 121 different entities began working on COVID-19 vaccines in early 2020. The vaccine development process begins with design and production of the vaccine. I don't know if you remember, somewhere around March of 2020, the AstraZeneca Oxford University collaboration announced publicly that there had been some hacking activity into their servers and the vaccine designs and so on. And many persons just dismissed that. Of course, they thought it was the Russians because they're very good at that type of activity. We don't know for sure who it was, but it turns out that the Russian vaccine design is very, very similar to the AstraZeneca Oxford University design. The Chinese vaccine design is different. Um, and so, if we could speculate about that particular activity. However, of 121 different entities, some state owned, including the Cuban government, the Russian government at Gamaleya Lab, the multinationals of AstraZeneca, Pfizer, other universities, including universities throughout the US, those with the capability for vaccine production, many entities began research. You can go on the WHO website and see various products still at various stages of development. Some of them made it to phase 2, where they had animal trials and found that the product did not perform as was planned or as suspected, as expected. But many of these products are still in the pipeline. Your ability to get things through depend on the resources at your disposal. We've seen recently where the Cuban government was able to come out with at least 3 different items based on multiple designs. One of them is a nasal spray that they're trying to bring out as a vaccine. But the ones that are currently being mass produced are injection vaccines. And so the Cuban government there are many countries, even China has produced two vaccines, the Sinopharm and Sinovac. Um, at least 15 of them were shown to be working in this third stage of trials, which are human trials. In other words, they were saying we're getting good antibody production from these vaccines. And so those 15 um, are the ones that have been in use around the world. However, um, the stages at which people volunteer for testing these vaccines really began in March and April of 2020. So while we were at home and we were wondering what's happening, the medical and scientific community was at work. People volunteered. In fact, in one trial, over 150,000 persons volunteered because they saw what was happening around them. People volunteered to participate in these trials. In some studies, up to 50,000 persons. In some studies, way more than that. AstraZeneca, Oxford University had a large number of volunteers. So shots began to go into arms in human volunteers by March and April of 2020, and continued. The cohort was studied up until about September. So if you understand how a trial is done, if a company comes up with a product and they want to if a company comes up with a product and they want to know if it works, then the company cannot be the one responsible for administering the study. And I want to make that clear. There are many people who feel that because a product is labeled AstraZeneca or Pfizer, that Pfizer was responsible for deciding what is reported or what is not reported with their product. That's not the way it works. Otherwise, there would be no real standards, and you'd have a lot of hanky-panky going on. So if you wanted to conduct a study, you would have to come up with a study protocol, but you'd have to hand over the implementation of the study to facilities that are equipped to manage the study. And at that time, we call it a double-blind study, which means that the people who are participating in the study are not exactly sure what they're receiving, and the persons who are administering medicines do not exactly know which patient is getting what. So it's double blinded, and it is coded in a way that after some time you can remove the blinds and see what the outcomes of the study are. That data is in the hand of clinicians, doctors, and institutions who have participated in the study. And therefore, medical scientific information is considered to be reliable if you have gone through this particular process. So we're talking about reliability of information that inspires confidence and trust in the outcome of studies that are conducted properly or correctly. So the reason why I mentioned that is because the controversy with regards to COVID-19 is really a trust issue. We're all exposed to so much information, different information that's coming from different corners. Everybody has a platform on which to express their own opinions and their feelings, their concerns about something, but we are not entitled to our own facts. And what is really happening is that many persons have lost trust in um, in particular sources because they believe those sources to be tainted, maybe politically or financially influenced, and so on. The thing is that you take a section of the society, the healthcare professionals, whose job it is to look out for the interests of people, to provide health care. Someone who you would trust to go to if something was happening with your health and you could not solve that problem yourself. Not all of us, not everything gets better with some ginger tea and so on. And you go to a healthcare professional because you depend on their integrity, you depend on our professional training, you depend on our experience, and most of all, you depend on the belief that we have your interest at heart. So this has become really a trust issue. And the question is, do we live in a world today where people still trust that a doctor or a healthcare professional will have the interest of a person at heart and want the best possible outcome for that person? Okay? So the studies which were done with regards to vaccines, it became very clear. Ms. Peniston, I just want to ask if you could just mute your microphone, please. Ms. Cheryl Peniston, thanks.
Sorry,
So,
sir.
you're welcome. That's okay. So, the studies that were done in the third phase of vaccine trials over a 6 month period between March and September of 2020 indicated that persons who had received vaccines in those trials were protected to some extent, approaching 90% protection from the severity of COVID 19. It was never 100%. And we know that basically you can't say that that vaccines are 100% because there's some persons who don't even have a strong enough immune system to respond to a vaccine adequately. And so there's some people who will be vaccinated, but they may still be at risk because their body may not produce an adequate response to the vaccine. And that's true for many vaccines. Um, as a healthcare provider, during my training in the UK, I was required to be vaccinated against hepatitis B before going into hospital. Um, that was a mandatory vaccine. And if you wanted to have the training and to work in a hospital setting, even here in St. Vincent, you're required to have hepatitis B vaccination. Now, the protection that hepatitis B vaccination offers is somewhere in the range of 30 to 40%, but yet it's mandatory. And we don't have a high burden of hepatitis B in the population in general, neither in the healthcare working population. So the question about whether this why should hepatitis B um, vaccination be mandatory for healthcare workers? Why is that a standard around the world? Um, that's something that may be more important to discuss than COVID-19 vaccination because we actually are seeing an outbreak of COVID-19 here in St. Vincent. We're seeing more and more cases every day. We're seeing lots of young people, including children, testing positive. I've had at my office a few preschool children who tested positive. And we've also seen a number of preschool teachers who have come in recently testing positive for COVID-19 and with symptoms. Um, for that reason, I believe that most teachers should see themselves being at extra high risk. We have the experience of a viral flu in 2019, which caused a short closure at Girls High School. So many students and teachers out sick with the flu that there was no point in continuing classes as usual until there was some recovery. Perhaps at that time it would have been a good idea to encourage people to wear masks and to sanitize to try to reduce the risk of those outbreaks. But in the teaching in the classroom, a teacher is going to be exposed to children who are not always cooperative, who are not always obedient. They won't wear their mask all the time, even though they're told to. They would be sent to school even though ill, even though you've made a protocol to say, please don't come to school, don't send your kids to school if they have a fever. But yet, a child lying with the head on the desk, feeling very unwell, maybe coughing, who responds? Who's the first responder for that kid? It's generally the teacher. Another child might notice, but they're going to call the attention of the teacher. And I I from my experience as a teacher remember many days when my classes were interrupted by students falling ill, and in some cases we had to manually lift children to take them to a sick bay or to some area where they could have additional care. Um, and the thing is that the contact between teachers and children is a sustained contact. In a classroom setting, you're going to be there for a while. And so the risk of COVID-19 exposure to teachers is very high. I can think that the only persons who are likely to see more COVID-19 exposure than teachers would be healthcare workers in the acute care setting, like the emergency room or the ICU or a COVID ward, where you're definitely you're definitely in contact with known positive cases. But guess what? Knowing that you're dealing with COVID-19 requires you to have certain protections in place. So a nurse who goes into work in the COVID ward, apart from saying her prayers every morning, will put on personal protective equipment that is certified to protect them from the exposure that they will face. That equipment is not available to teachers in a classroom. And so we come to the issue of treatment and prevention for COVID-19. Well, since the outbreaks began, many persons have been trying to find, physicians all over the world have been trying to find medicines um, that could reduce the severity and maybe improve the condition. When the infection got to North America, it seemed to have skipped over Africa. And many persons suggested that maybe the African continent had been exposed to so many other illnesses that the use of malaria medicines may have been protective. And in came the issue of hydroxychloroquine, which is the most commonly used medicine to treat malaria in the African subcontinent. Um, Randomized controlled studies proved that hydroxychloroquine did not improve the outcome of persons suffering from COVID-19. It did not reduce the severity of the illness. We've had other medicines that were tried. We have remdesivir, we have the HIV antiviral agents, we have other agents which were used in the past for flu. And it takes a while before anybody can come up with brand new agents for treating an illness. So people were trying to see if anything that we were using before could work. And there was a lot of talk about um, ivermectin in Southeast Asia, in Brazil, and so on. The Indian government announced today that they've given over 1 billion doses. They gave their 1 billionth dose of AstraZeneca vaccine, COVID-19 vaccines, to persons living in India. A billion in India alone. And what I want us to understand is that even though India had an infrastructure in place for distributing certain drugs like ivermectin and so on, it is really a mass vaccination campaign that has made the difference in India in terms of slowing down the epidemic that was taking that country. In the cities, for example, where there's high population density, and then out into the rural areas. So after so many persons passed away, I believe that they realized that their situation was quite grave, and more persons were willing to accept the vaccines in India. They have a higher vaccination rate than we have in the Caribbean. So, since 2020, we've also seen the infection pick up in sub-Saharan Africa, so that even though, like us, they were slow to experience the severe outbreaks, they're also beginning to see the situation that we're experiencing in the Caribbean. So it obviously is clear that the climate or the medicines like malaria medicines really was not the protection. What kept COVID away from St. Vincent for so long? It has to be the number of persons who are moving in and out, the amount of traffic that was coming and going from St. Vincent. Remember, the airlines closed down pretty early, and so we had limited people movement in and out of St. Vincent. And so you had a controlled population that you could easily test and quarantine and so on. And so most of our cases at that time were imported cases. Whenever that guard is let down and people are allowed to travel, it is very easy to see how you could have a local outbreak. So medicines, the search for medicines is still ongoing. Merck company recently announced that they are they announced that they are about to seek for approval for a medicine that has been shown to reduce the severity by about 50%. And this is especially useful for persons for whom the vaccines may not work, or who may not be eligible for vaccination. So a lot of the issues with regards to the treatment of COVID-19, while the WHO and other national bodies, governments, and so on have been recommending vaccination as a solution for reducing the burden of disease caused by COVID-19. It is based on the fact that vaccines in general teach your immune system how to respond to an illness. The vaccine itself introduces a messenger RNA into the human body. The messenger RNA is a short-lived molecule. It does not continue to survive for any extended length of time. It interacts with an organelle in cells that is called the ribosome. The messenger RNA is a copy or a blueprint for the spike protein, and after the spike protein is produced, the messenger RNA is generally degraded. So after copies of the spike protein is produced, the messenger RNA is degraded. The spike protein survives in the human body for about 2 weeks before it is also degraded. What happens after vaccination is that the immune system has had an exposure to a part of the virus, which is the spike protein. And from that part of the virus, the immune system begins to make antibodies to fight back against the virus. Now, we are going to come to the issue of safety of these vaccines. But first of all, there is no question about the fact that persons who were vaccinated against COVID-19 had a greater degree of protection against not just becoming infected, but also the severity of the illness if they did become infected. It was quite clear from the early trials that were done. But after the trial phase, when the vaccines were rolled out into the general population, remember, at this time, you would have a larger cross-section of the population receiving vaccines, including people with medical conditions that had not been tested before, persons who were immunocompromised who may not have volunteered for a vaccine trial. And so it is quite easy to see that different things would be picked up in the general population that would not have been picked up during a controlled randomized trial. So for every vaccine, not only is the data during the trial phase important, but after it has been approved for use in the population, further data is gathered, accumulated, that will affect positively or negatively the safety profile or the understanding of the effectiveness of the vaccine in practice. It is still the view of the general medical and scientific community that COVID-19 vaccines are effective in reducing the numbers of new cases. In countries where the vaccines have large uptake, they have all seen a decline in new cases, and they've also seen more protection. Of course, you will see persons in between who become infected because their immune system may not be adequately protective even after vaccination. So, let's talk about the risks of vaccination. Because a lot of people think that we only talk about the benefits of vaccines. It is, as I said before, there is clearly an improvement in the statistics of infected persons and persons with severe disease. Somebody was suggesting that maybe it's just based on the proportion of the community that became infected. But if you look at the numbers of persons admitted to hospital who are vaccinated versus those who are unvaccinated. Um, in countries where more than 50% of the population has already been vaccinated, the vast majority of people admitted to hospital are still unvaccinated persons. Okay. Um, risks. Risks of immunization. Whenever a person is given a vaccine, the vaccine provokes an immune response, an immune system response, which is inflammatory. And there are some people whose bodies, whose health or the level of health at a particular time could be so frail that their body may not be able even to withstand that level of inflammatory response that can be created by a vaccine. So when the vaccine is given, a foreign material is administered to the body. The body responds by the immune system um, identifying that particular type of protein and producing antibodies to fight it. There's a battle that's going on between the immune system and that antibody and that antigen or protein, and that produces an inflammatory response in the human body. For some persons, their heart may not be able to handle the the racing of the increased heart rate that a fever reaction might produce. During that response, your body releases inflammatory substances, which we call cytokines, and these cytokines can produce an inflammatory reaction. And that's why after a vaccine, a person can have a fever, a person can have pain and aches in the body. So there's this inflammatory response taking place. And so we know that not everyone is in a state of health that they can necessarily withstand this particular issue. What I think is that each person should have a concern for their own health about the state of health that they're in. The vast majority of people can go to their healthcare provider and take a tetanus shot if they needed it because the reaction or the inflammatory reaction that follows a vaccine is usually something that your body can handle. But the persons living or exposed to COVID-19 could be anybody. It could be an elderly person, it could be a person with a previously known underlying condition, and so on. And so it is easy to understand that even a person who is um, in in poor health may not be in a position to receive a vaccine at a particular time. Maybe they are unstable at that time. A person with a very high blood pressure, where that high blood pressure poses a risk to their health, that is not the time that they should be experiencing a further inflammatory reaction on top of that. And so persons should be concerned that their health condition is stable before receiving a vaccine. And I'm saying a vaccine because it's not specific to the COVID-19 vaccine. If you decide that you're going to travel to Trinidad tomorrow, the Trinidad government requires you to be vaccinated against yellow fever, as does some other countries. And the thing is that just to go to get the shot because it's a requirement to go to Trinidad is one thing, but to have an understanding of your health and the risk that it may pose to your health is another thing. And so there must be a conversation about those persons who may need to be delayed or exempted from having vaccines. I've said in the past that I've had patients come to me to ask about vaccines. One lady had just received um, a bone marrow transplant, and that was not the time for her to be exposed to a vaccine. And therefore, she was advised not to be vaccinated. In fact, um, after giving that advice, she contacted her doctors in the United States who had provided treatment for her a year ago, and they also said the same thing to her. She was able to travel to the United States earlier this year to continue her checkups and her treatment. Not everybody is able to have a vaccine, and therefore some persons um, may have need for some exemption status. Um, the vast majority of people, though, will be able to safely have a vaccine without any consideration for this response. There are many reports of persons who have died after receiving a COVID-19 vaccine. It is not clear, there's no specific data to show that there is an increased risk in the population of vaccinated people for any specific health condition. We've seen persons who have sudden death related to heart issues. We know that people can die suddenly at any time. But in the population of vaccinated people, there is no data to suggest that a certain percentage of the population is at higher risk of death. We know that that percentage exists in persons who become infected with COVID-19, that up to 1 to 2% of persons may actually die from the illness. But if you take vaccines and say, well, what percentage of vaccinated persons would you expect to die within the next month or two? Then the question is really how serious is the risk that is posed by vaccination? And so we have to be able to balance the issue of benefit versus risk. And this is perhaps the most important conversation that we should have when it comes to COVID-19 vaccination is benefit versus risk. I'm not going to say that there is no risk for persons being vaccinated. But the question is, and I've had conversations with persons who drive regularly. I've had some drivers who say that they don't wear a seatbelt because they think that they will be in a better position to jump out of the vehicle if they don't wear a seatbelt. And so they're willing to take the chance to drive down the road and perhaps face a head-on collision with another vehicle, not wearing a seatbelt. The reason why seatbelts are mandatory in St. Vincent and many other countries around the world is that it has a proven benefit. of reducing the impact in a road traffic accident. The impact and the level of injury is significantly reduced. Of course, there are some people who have been able to quickly jump out of a vehicle which is turning over an embankment and have managed to get to safety. But the number of persons who've actually survived by jumping out of a vehicle is so small. The number of persons who have been saved by wearing a seatbelt while tumbling over an embankment is much larger. And so, for a person to say, I will not wear a seatbelt because I think that it presents more risk to me than benefit, that is definitely not borne out by any scientific fact or data. Far more people have been protected and saved by wearing a seatbelt than the persons who have jumped to safety. So, when it comes to vaccines, would you rather encounter COVID-19 illness in a classroom without your seatbelt on, without some measure of protection, simply because you're afraid that if you were to take the vaccine today, that some untoward outcome may cost you more than you're willing to pay? And I want us to look at these untoward outcomes. So there are many people who are afraid that if I take a vaccine, that something is going to happen to me, something serious. That ranges from sexual dysfunction, infertility. People worry about sudden death, dropping down, getting a stroke, getting a heart attack. I've heard lots of people who ask about, what's the vaccine going to do to me? And this is the real question that we need to be able to answer to people. So in the studies that presented data about blood clotting risk after vaccination, and we are not able to say that there is no risk of blood clotting. I believe that there is some scientific data to suggest that the spike protein, which is generated after a vaccine, can actually be implicated in some coagulopathy, as it is with COVID-19 illness itself. So the risk of blood clotting from COVID-19 is far higher than the risk of blood clotting from the vaccine, but still the risk exists. And for people who have had previous blood clotting disorders, there should be a special consideration for those persons, because you could either mitigate that risk by using some agent which is able to reduce the risk of blood clotting, or protect that person um, by avoiding the vaccine or having an exemption. However, that person must realize that their risk for getting COVID-19 is still as high as ever, and that their only protection will come from persons around them who have been vaccinated. So you're between a rock and a hard place, in a sense. The decision whether to face COVID-19 infection, which is a very high risk, especially for teachers, or the decision to take a vaccine, in which the risk exists but is considerably small. In the United Kingdom, the system for tracking post-vaccine reactions was very well developed, especially for this vaccine. there was a combination of self-reporting and physician and healthcare worker reporting. And the 30 cases of blood clotting syndromes that were reported was seen after 55 million vaccines were given. That gives us a rate of close to 1 to 2. In fact, later studies were suggesting maybe 1 to 2 cases of rare blood clot per million. Think about that. Among vaccinated people, an event that happens 1 per million. You give a million shots, and one person or two persons report a blood clot. First of all, it would not be very clear to say that the vaccine was what caused it, because you think about cause and effect, you would want to say that maybe more people would have to report that for you to say that it's a cause. But in medicine and in science, we do not discount those reports. In fact, they should be investigated to see if there is a specific interaction between the vaccine and some particular person's makeup or composition that would lead them to be at higher risk. But we can also not discount the fact that vaccines are being administered in a setting where there's already high COVID-19 penetrance, and previously infected persons are among the risk group, and persons who may not know that they're infected or had COVID-19 are among the persons seeking vaccination. And therefore, it is really confounding to say for sure that it was the vaccine that was responsible for blood clotting events. However, based on the statistics, vaccine safety has been established because we're talking about billions of people now around the world who have already received the vaccine, and we have not seen mass burials of vaccinated people anywhere in the world. There is no event of mass burial of vaccinated people anywhere, but we do see mass burials of unvaccinated people in cases where there is massive outbreak, overwhelming the healthcare system in many countries. And so the risk of getting COVID-19 without the vaccine protection is far higher than the risk of something untoward happening as a result of vaccination. Finally, I want to talk about the ethics of vaccination. There are many people who consider receiving a vaccine as an invasive procedure, and therefore there should be informed consent. Persons should agree to receive a vaccine, understanding its benefits and its risks. And I am in agreement with persons being presented with benefit and risk information regarding vaccinations. I believe that we have lost a lot of time with the notion of what information we should accept as factual versus fiction. We have a situation in our country where people are far more likely to repeat a juicy story. So Dr. Nedd does not show up at work today. And the person who is living in Dr. Nedd's neighborhood, who works in the same place, say, Dr. Nedd must be gone on the beach. Maybe saying something flippantly, maybe saying maybe saying that Dr. Nedd probably just taking a day off, is not at work today. The chance that someone else hearing that statement will repeat it without critically thinking is very high. it's going to also change as it goes down the chain. So what went from Dr. Nedd must have gone to the beach today, in a few steps later is going to become Dr. Nedd say he ain't coming to work because he preferred to go to the beach or something else. It's going to change, it's going to morph. And we have a situation now where that information, anything that somebody repeats, without maybe asking, where did you get that information from? What's the evidence to support that? What's the truth of that matter? It is easy to see how very quickly, with everybody having a platform on which to repeat things that they have heard without having it fact checked, that you could be bombarded with more news that is misinformation than actual factual information. People say, well, it's difficult to come by the facts, it's difficult to understand what really happened. Well, if you wanted to know where Dr. Nedd was and when he missed work, somebody could take the decision to call Dr. Nedd and find out if, what's happening with him. But instead, very often, because we have a culture of gossip, gossip has taken over the way we handle information. And therefore, the question of how to critically appraise information we have received, sometimes maybe who you're receiving it from, what is the exposure of that person to this information, and so on. We need to have far more serious critical review of things that we receive and we're going to repeat. I have received many of the messages that many persons have received by persons either claiming to be doctors. Many of them are homeopathic practitioners. When I say so, I mean many of them started off maybe more on the herbal side of school, and they're naturopaths, which means they stick to the notion that the body is far capable of healing itself and overcoming illness, and you don't need to interfere with that process. I think that if you're going to hold to that view, that we might as well close down the hospital. And if your belly hurt you in the night and is your appendix, just leave it, because interfering with that process is going to cause a different outcome. But the question is it a better outcome? You have to ask yourself, and a lot of people have been talking about natural immunity, allowing people just to become infected and then see who survive and who don't survive, and hope that the people who survive have long-term immunity. I think the scientific and medical community wants to go past that. We've already seen what that does. In the outbreak in Italy, they wish they had access to a vaccine then to prevent the number of deaths that they saw. In the outbreaks all around the world, pre-vaccination, everybody wished that they had a method or an option for prevention or reduction in the death toll, for the numbers of persons who passed away as a result of this illness. In the United States alone, the number is approaching 800,000 deaths, compared to the seasonal flu, which generally may claim up to about 25,000 deaths per year. And so this is not flu. This is a serious illness that needs to be taken seriously. And it comes to meet you wherever you are. You could be at home and it can come and meet you at home. One patient who came to see me, I did encourage that patient to be vaccinated against COVID-19. And based on my knowledge of her health, she had actually suffered a stroke related to high blood pressure and high cholesterol and diabetes in the past. And I encourage that patient to be vaccinated because of her risk. The patient said, "I don't go anywhere. I don't think I need no vaccine because I don't go anywhere." Well, a few weeks afterwards, the family called me to ask for a home visit to see her because she had deteriorated and she was having fever and very weak. And my advice was for her to get tested for COVID and for her to be taken to the emergency department. At that time, she tested positive for COVID-19 and her condition had deteriorated. She was admitted to hospital. She spent a good few weeks in the hospital and went to the COVID ward. She ended up at Argyle. And finally, I was informed that she was discharged home in a stable condition, but was still testing positive for COVID-19. Um, Her physical condition, which I had seen her at the time when I recommended vaccination, has significantly deteriorated, and she's not able to have the mobility that she had after she had recovered from a previous stroke. So COVID-19 can come to meet you at a moment when you least expect. Young people feel like they're around family. Many of us don't wear a mask at home. If you look at the poll, just put that poll back up for me, please. And if you look at the poll results, um, um, the question number 2, do you wear a mask at home? Most persons do not wear a mask at home, but yet at home we have people, other persons in the household who are coming and going, and we trust that they're taking actions when they go out that would be protective of the household. During the time when you are unmasked, your risk of COVID-19 infection increases significantly. And this happens generally in the workplace, in the back room, in the lunchroom, in the bathroom. People take off their masks. They may have conversations with other coworkers, but they trust that that work is not having symptoms and therefore low risk. But we have seen that even in vaccinated persons, this is the time when the risk is highest, when persons are not wearing their masks. So it's high risk at home. Guess what? The kids are not vaccinated, and if they go to school in the classroom, it's likely that COVID-19 will pass rapidly and this has been demonstrated in the United States, that you see a spike in cases in the community when schools reopen because if kids don't wear masks or it's not mandated for kids at school, that um, you have an increased transmission or children becoming infected and taking it home to their parents, their aunts and uncles and grandparents in the home setting. Remember that most people, according to our poll, how many participants did we have here? Anybody could help me? How many people completed this?
110 persons.
Okay, so out of 110 persons, 77% said that they did not wear a mask at home. And I'm not suggesting that you have to wear a mask at home, but you have to consider the risk of being around a person in the home setting, sharing the space, where other unvaccinated persons or even vaccinated persons who may not follow these protocols 100% in terms of public health protection, primary prevention activities. The people who wear a mask at home, maybe they have been exposed. Maybe they figure that there is a high risk in their home setting based on the movement of persons around the home. Definitely, if someone close to you have been infected, you should be wearing a mask at home to protect other family members during the time that you're in that space, except for being in your own single space, which is not shared by other persons. It's interesting that the setting of the classroom, which we have already agreed is a high risk setting, that we are expecting to depend on primary prevention, which means that you do all you can to avoid contact with the infection. And that is still the number one recommendation. I don't want people to forget that the number one recommendation for protection against COVID-19 is primary prevention, which involves this social or physical distancing, mask wearing, and sanitizing, regular cleaning of surfaces and hands and so on. There are other things that you can do to improve primary prevention. You could set up ventilation systems that allow the airflow to move in one direction. These interventions are generally more costly. You could have what we call laminar flow ventilation so that the air in a room is constantly moving in one direction, goes out, comes in one way, goes out the other way. I don't believe that we have the full facilities even for implementation of good primary prevention strategies. We've had the experience in the past year when we did not have COVID in our community. We didn't have massive outbreaks. But I want you to think about what happened last year when we returned to school for the 2020 school year in September of 2020. How much compliance or adherence was there to mask wearing in kids, in students in school? How many of them wore the mask above their nose? How many of them would follow the temperature logging and sanitizing procedure that should be in place at entrance and exit from the school, or moving around, and how many of them had lunch at school versus going out somewhere to have lunch. How much control do we have over this? To what extent can teachers police the public health requirements? As a physician in my own practice, I have given instruction to staff to insist that patients coming in should wear the mask correctly and that they should sanitize correctly. We have provided soap and water as a superior cleansing agent for COVID. I know many of you have become used to using hand sanitizers, but you put a little dollop of hand sanitizer in your hand and you rub your hands together Most of it is gone. By the time you come over to the back of your fingers, you might do the back of your fingers, but you don't get the complete coverage that soap and water would give you if you wash your hands properly with soap and running water. And so, in the instances where soap and water is not available, alcohol-based hand sanitizers are recommended. Um, so we were talking earlier about the ethics, and the question is, to what extent, to what extent is it the responsibility of anyone in authority to mandate a public health measure? And this is something that is currently being discussed by ethics committees all over the world. Well, in the hospital and healthcare setting, there is adequate precedent for mandating public health and safety requirements. Many persons understand that if you are employed, that your employer shares some of the responsibility for looking out for the health and safety of workers. If you work in an area where you're exposed to particles, you should be provided with a mask. You should be provided with certain personal protective equipment, and it is no wonder that the national at the level of St. Vincent and the Grenadines, public health and safety legislation, which has already passed through the parliament, is stuck in limbo because the biggest employer in this country would face a significant challenge if that employer had to provide all the needs for health and safety for all its employees. The upfront cost is going to be very high, but also the responsibility for putting things in place to check and checks and balances and so on. But it is still the responsibility of an employer to look out, to have the interests of workers at heart, and therefore provide um, health and safety guidelines and equipment for persons who are at work. Now, the question is, does the issue of COVID-19 and the transmission of COVID-19 in the workplace become an issue for health and safety in the workplace? And the answer is yes, it is a health and safety issue, because a person may come to work uninfected and leave infected. So it is a health and safety issue. Some of those infected persons may not survive, and they could very easily have picked up um, an infection in the work environment. Whose responsibility is it to put things in place to try to minimize the rate of infection or the risk of infection? And you will say, well, this is a shared responsibility, and I agree, because from health and safety perspective, the guidelines are put in place and the protocols are put in place by the employer, but the adherence and compliance to those protocols depend on the end users. I believe that there are many persons to I believe that there are many persons who recognize that an employee is serving or providing services to an employer under conditions stipulated by that employer, and that employee is the one who has to decide if they're going to continue working under those conditions. It is true that from an ethical standpoint that an employer should look out for the health and safety of a worker. And if the conditions of work become so serious or so much risk for a worker, then that worker has a legitimate reason to lodge a complaint, and that there are bodies which will look out in the interest of the health of the worker. And so the question is, when it comes to a public health issue like COVID-19, to what extent is the responsibility of the employer to protect workers from infection with COVID-19? And to what extent is the responsibility of the employer to protect people from other risks associated with the COVID-19 pandemic? For example, vaccination. I mentioned before that there are some risks, but those risks are already determined to be very small. The conversation will continue because many persons in this beloved country are really, really afraid of taking this vaccine at this time. Many persons are saying that it is too early, that there is not enough information about the vaccine, or that there is not enough track record or safety record about the vaccine for them to take a chance or to take the risk of having it. But yet, those persons are willing to accept the risk of experiencing COVID-19 without a chance of protection against it. I wanted to suggest that the information regarding the illness itself has been actually shadowed by the conversation regarding the vaccine. The illness of COVID-19 is far more formidable. A patient who came into the Milton Cato Memorial Hospital a couple of months ago to have a cesarean section was taken to the operating room, and during the procedure, the anesthesiologist found it very difficult to maintain the oxygen levels in that patient above 94%, which is normal. The patient had no history of asthma or respiratory illness. And after a safe delivery with, having to give large quantities of oxygen and so on, after the safe delivery and recovery of the patient, questions were asked the patient about her health condition. It was afterwards that she came out and finally admitted that she had had COVID-19 the previous year prior to her pregnancy. And in further investigations, it was found out that she had significant lung scarring as a result of COVID-19. What I'm saying is that COVID-19 has the potential to change the landscape of St. Vincent as far as our physical health is concerned. We run the risk of running low on resources. Right now, for example, persons requiring cardiac care and maybe some other specialized care who would attend a public clinic have no access to public clinics because public clinics are closed because of the high rate of COVID-19 in our community. Patients are being sent home way earlier than recommended from the emergency room with serious conditions because of accommodation difficulties. Persons with a stroke are sent home before any preparation can be made at home to take care of those patients adequately, simply because of issues that are current with accommodation. And if we get to the place where the entire hospital is overrun, taken over by persons with severe COVID illness, you could understand quite easily how persons who are not COVID infected could be denied access to care because of this illness. But we've seen a complete turnaround in countries where the vaccination rates are higher. In some countries, I noticed that for the Caribbean numbers, the Cayman Islands, even though they've seen some infections, they've seen more cases than they had previously. They have a very high vaccination rate. The Cayman Islands are not reporting any increase in medical health conditions or deaths related to vaccination, even though over 70% of their population is already vaccinated. Countries that are returning to some level of normalcy, where people are attending, students are attending school, people are catching the bus and mass transit and so on, where there are high levels of vaccination, there is no documentation that there is any increased risk for any particular condition. And so, for persons who are thinking that there is a high risk of sudden death or stroke or heart attack or heart disease, there is really no data coming from anywhere in the world where vaccination rates are high to suggest that this is the case. There is anecdotal information and observational information, which I mean by a person took a vaccine last week and they died this week, and automatically we make a connection between the two. The question is, how are you going to determine that this person is has died as a result of taking the vaccine? One way is to look at population studies. You take all the people in St. Vincent who have had a vaccine so far and count how many persons who died as a result of taking the vaccines. And if you look back at this poll, and if you could just bring the poll back up for me, so we could have a look at that question. So most of us already know a person who is hospitalized with COVID-19, but maybe we're waiting for it to be one of our family members or somebody very close to us before we consider a protective approach with vaccination. The question of whether anybody knows anybody personally who took a COVID-19 vaccine and died within 2 weeks. And I'm a little bit surprised because the answer for yes is 28% of persons who say they know this person or one person who they know died within 2 weeks of receiving a COVID-19 vaccine. And the vast majority of people don't know anyone who died within 2 weeks. I don't know if everybody answered that truthfully because we're talking about within 2 weeks here. But the issue is that there is no data anywhere in the world where COVID vaccination is given to suggest that people are dying at any significant rate higher than the normal observable death rate in the country. If you took all the people in St. Vincent tonight and you vaccinated everybody, would you expect anyone to die tomorrow, or would you suddenly confer um, immortality on this bunch of people? It is obvious that you would still expect some people not to make it through the week. But the question is, did they die as a result of the vaccine, or did they die from something else? Um, I had a good friend who actually worked alongside when we were putting together the physical setup at Advanced Health. Um, he he had some health issues, but he didn't come to see the doctor. In fact, I had encouraged him on multiple occasions to come in for a checkup, which I was willing to sponsor, free of cost for him because he had been so helpful with our work. And I heard recently some commentator in public stating that this person died as a result of taking the COVID-19 vaccine. And I am not going to say that it is not possible that a person can die subsequent to taking the vaccine or as a result of the inflammatory response. But in many persons, there is an impending disaster in their bodies. There are many persons who walk around with chest pain who already know that they are tired and short of breath as soon as they walk up the stairs, or that they have an underlying health issue that they have not been paying attention to. And it is very clear to me that the inflammatory reaction from a vaccine can push that person over the edge. But that person had is an underlying condition which we would call a ticking time bomb. And if it had not been for this particular reaction with fever from the vaccine, it could have been the next time they catch a cold, or it could be the next time they exerted themselves too much, that would push them in that direction. And so I am making it very clear that the people who are likely to suffer a poor outcome as a result of vaccination have already an underlying condition which is aggravated by the inflammatory reaction created by the vaccine. But apart from that, most persons with a normal or healthy immune system will be able to tolerate vaccination without any such risk. Most of the persons who are at risk for a worse outcome, you would surmise that those might be persons in the age group over the age of 65. But even in that age group, persons who are in nursing homes and so on, um, it has not been observed that there is an increased rate of death after vaccination. And so the question is, where does this fear come from regarding people dying? And it takes me back to the same issue of what we choose to believe. It is important. That young man who I spoke about earlier, when his postmortem examination was conducted, his coronary arteries were blocked in multiple places. He had a massive heart attack where the muscle of the heart had actually ruptured. So he died from a heart attack, and he had been having symptoms of a heart attack for at least 3 days and did not present to healthcare until his final hours. And so I am not going to believe that a person with extensive heart disease, which had to have taken place over many years, that I would say that that person died directly as a result of the vaccine, even though the vaccine may have tipped the scale to cause more inflammation at this particular time. So while I'm making it very clear that vaccines are not without risk, the risk associated with vaccination is so small that the benefits far outweigh the risk. And it's not only for the COVID vaccine, but it is a condition that is observable with any vaccination. The only trouble is that we have not had mass vaccination campaigns for many illnesses because they are not pandemic. We are still in a public health emergency, and for a reaction to this emergency, which falls on the authorities of the day, they have to make decisions based on what is known, based on what is proven, and in the interests of the majority of our population. That being said, there are opportunities for persons to be exempted from vaccination. There is a committee already set up, and I know that some physicians have been contacted about being able to write or issue statements or letters of exemption for persons who meet certain criteria which are internationally accepted. Okay, so finally, I want to look at the other questions that we didn't address in the polling. I noticed that persons who were responding to vaccine hesitancy in St. Vincent were not specifically convinced that vaccines are obviously, COVID-19 vaccines are clearly unsafe. And so, this is almost contradictory because people have accepted that there are enough people in St. Vincent who have taken this vaccine who seem to be quite fine, and seem not to be ending up in hospital with COVID-19. But the thing is that there are other reasons. The fact that some people and the majority of people say that the information that they have is contradictory or controversial and therefore creating confusion in their minds makes us understand the extent of the misinformation, or they call it infodemic, that is taking place in the world today. If you have enough competing voices, people who are trying to speak persuasively about an issue that you are not well versed in, and many of us have listened to some of these audio clips. The most recent one coming from somebody who identified himself in Barbados about being about Digicel making vaccination mandatory. Many of us have heard that clip, and there are statements there of a technical nature where he reports that the spike proteins are going to become infectious and move from one person to another, and it can be transmitted, and the vaccinated people are the ones infecting other people with their vaccines or their spike proteins. Clearly, this person has very little or no understanding of the immunology that is involved in spike protein um, stimulating the immune system. A spike protein cannot replicate itself, it's not a living thing. And as far as we understand, with living things, reproduction is one of their main characteristics. A spike protein is a physical entity, it cannot multiply itself, it cannot replicate, it cannot be transmitted to another person and cause another person to become ill. And so, understanding the information that is coming towards you, while it may be presented in a very persuasive way, with persuasive language, and maybe even references to information and data, you would have to have some connection to the sources of data to read for yourself to see if the interpretation that is being put forward is true. I want to give an example. There was a study done in Japan in the early stages of Pfizer vaccination that said that spike proteins were detected away from the muscle. Now, the way the vaccine is designed, when you inject into the muscle, the messenger RNA is expected to move into the muscle cells and stimulate those muscle cells to produce spike proteins. The spike proteins are produced and released into the tissues and in the bloodstream. And even though the studies showed that small concentrations of spike proteins were found as far as the distal extremities in those persons, there was no statement in that study to suggest that there was any negative impact of those spike proteins being found in those parts of the human body during the vaccination process. However, that person who was commenting took that statement and said that because the spike protein can migrate, it is likely that persons who are vaccinated would then develop blood clotting events in those distant parts of the body, and therefore a vaccination is unsafe. Your understanding of material that is presented when everybody has a platform on which to speak is going to be muddied, as we say. You muddy the water and then nobody can see clearly. Confusion is one of the ways in which we can stall the development process in any area. If a person just wants to throw a spanner into the works, then they can go ahead and do that. And one more thing, just bring the the poll back up. But if you notice that most persons said that the information is too contradictory and controversial because this is a new issue and they've heard so many different things from different sides. A sizable number of persons have indicated that it makes no sense to take a vaccine if you can still get an infection after being vaccinated. And I tried to explain this by the seatbelt analogy a while ago. If you are vaccinated against COVID-19, if and in the event that you do become infected, the impact of that infection is much less. In fact, persons who are vaccinated tend to have a mild course of the infection, and it generally lasts about 5 to 7 days before they test negative again. In rare cases where the vaccine did not work in that person's body, that person may have a more severe course of illness. And so there are some patients like Mr. Colin Powell, who was on the news recently, passed away in the United States because of COVID-19 infection. But he was struggling with multiple myeloma, a disease that affects the bone marrow, and therefore affected the ability to produce normal plasma cells or B cells in his immune system. Because of that, even though he was vaccinated, his immune system could not protect him against COVID-19 because his immune system was dysfunctional. There are some people who are immune compromised, and while it may be safe for them to take the vaccine may not work in those persons. So for those of us who have elderly people at home who we cherish dearly, we may have them vaccinated, but the vaccine may not work. Do you know what that person depends on? They depend on the other people moving in and out of their presence being vaccinated and offering a level of protection for them so that that person is less likely to be exposed to COVID. It is clearly proven that persons who are vaccinated, if they become infected, because of the shortened duration and the reduced severity, that they do not produce enough virus, there's not enough virus multiplying in their body to allow for them to transmit to any significant extent. The period of transmission is shorter, and the extent of viral multiplication is significantly less. Vaccinations have been proven to reduce the viral load in patients, whereas there are studies that are showing that the use of certain medicines, including ivermectin, did not significantly reduce the viral load in patients who were infected with COVID. So I find the last question in the poll to be very important, very interesting. Right? Do you trust your healthcare professional has enough understanding to assist you with making a decision regarding vaccination? And so people feel like there's a burden to depend on themselves and their own resources to make this decision. This is question number 6. It is, I know we dealt with number 7 before, but we'll come to the answers here. What we are seeing is really a trust issue. When your car breaks down, who takes care of it? Who do you take it to? Well, there are many people who have an understanding of how their car works, and they're able to do some troubleshooting and check some minor issues, and they may recognize something deeper inside, and then they may take it to somebody who has the time. Not that they don't know how to do it, but somebody else is more professional. They have the tools, they have the time, and whatever. What is the world going to come to if everybody becomes an expert in matters of healthcare and healthcare response? I think the investment of time that is spent in training, because in order for somebody to become a professional, they must show evidence of professional training, even if it is by apprenticeship. You have to show that you have been in the presence of someone who had that competence and was able to pass it on to you in over a period of time. You must have professional training, and you must have professional conduct. There are many people who feel that they know how to teach, but they have not had professional teacher training. There are many persons who know about something through reading, but they may not actually be in a position to fully understand the technical nature of that particular area. And so it is very clear that many persons would rather look at information on their own and try to make a decision with regards to vaccines rather than perhaps seek the advice of a healthcare professional. And the question is, why is this? I'm not saying that you're wrong to do that. I'm not necessarily saying that you're wrong to do that. But I'm saying, why is this happening? What has caused this confidence in healthcare professionals to be so eroded? Or what has caused people to not be able to trust a physician who you would otherwise go to help you to deal with whatever health issue you have? I mean, I said earlier, if you have a bad belly pain tonight and you take ginger tea and it's not getting better, you're thinking next about who to go to or what to do for this. And there must be someone at some point outside of yourself that you trust may have professional training and judgment to help you deal with these issues. Who is that person? Who are those persons? What is the exposure of those persons to information regarding COVID-19? And that brings us to this, back to the sad state of affairs in this country with regards to continuing professional education. There are many physicians who recognize that they have a responsibility to their patients to have the best possible information, and they spend, or I should say, we spend a lot of time in reading and studying this technical information that is available. Not everyone will be able to digest it and understand it, but a person who has that orientation should be able to understand when there is evidence to support a benefit versus a risk. And so let's take, for example, the use of medicines to treat high cholesterol. In the 1980s, there was an epidemic of cardiovascular disease in the United States. Many persons had high cholesterol and there were heart attacks galore. And it was discovered and understood that if you treated a person who had had a heart attack with a lipid lowering medicine like atorvastatin or so, simvastatin and others, that you could reduce their risk of a second heart attack significantly and reduce the chances of that person dying from cardiovascular disease significantly. And you know what? As a result of those statins, cardiovascular disease is no longer the number one cause of death in the United States and has not been for the last decade or so. And the question is, but isn't there a problem with using statins? Yes, there is. There's some people who don't tolerate them well. There's some people who get inflammation of the liver when taking statins, but the vast majority of people can tolerate a statin drug and gain benefit by reduction of their cholesterol level to the point where it reverses their risk of heart attack and stroke. And so the decision of whether to prescribe it or not is based on a risk-benefit analysis. Yes, there's a risk that this patient may not tolerate it, but we know that the patient is likely, far more likely to suffer a poor outcome if we did not prescribe it. And so I want you to understand that the calculation, the analysis of data that's coming out from studies and so on, not everyone is able to digest it. And healthcare professionals should have some preparation through their training in epidemiology and public health issues, statistical analysis, study design, and conduct of studies, that we should be able to determine when a study is worth looking at, and perhaps the recommendations from a study, or not so much the recommendation, but the conclusions are watertight. We depend on professionals in every area of life to help us navigate decisions that we make. Um, I have patients who come to see me with a complaint, and I've prescribed the medicine, and they go home and they don't take the medicine. But they come back another time and say, Doc, I took the sick leave and I stayed home, but I looked up on Google and I saw the side effects of this medicine and I did not take it. Honestly, I was afraid to take it because I was afraid of the side effects. And in a sense, we don't spend enough time explaining to patients potential side effects and potential risks for medicines, including the antibiotics that we use to treat, pneumonias and bronchitis and infected legs and all sorts of things. But we know the difference between a good outcome and a bad outcome, and the use of medicines have been proven to improve the outcomes for many of these conditions. It is on the basis of this benefit to risk analysis that we make a decision to prescribe. And if a person doesn't have, is not likely to benefit from an antibiotic, we shouldn't be prescribing an antibiotic. We have patients who come in with a cough and cold and say, Doc, I just come to get some antibiotics. What do you mean you come to get some antibiotics? You should be coming to get an examination to determine if you need antibiotics. That decision is not yours. It should be a professional decision. But people have been sidestepping that and going directly to the pharmacy and asking for antibiotics, and in many cases, they procure the antibiotics. What long-term effect does that have on the population? Well, it causes resistance to antibiotics, and it causes patients to end up not being treatable by the same antibiotic when the time comes when they actually need it. And so there is a lot of consideration that goes into a clinical judgment or decision. And healthcare workers should maintain the trust that persons have to put in them, because very often patients put their life in the hand of a healthcare worker. And it is the responsibility of that healthcare worker to remain up to date in their field or in their profession, even if it is not mandated. And I will tell you that the vast majority of health professionals in St. Vincent do not take continuing professional education seriously enough to maintain that trust. But it is not impossible for us to to um, to change that when it comes to new health issues that are affecting our population. It is sad that many healthcare professionals did not consider themselves knowledgeable enough to either recommend um, or to discourage patients from taking a COVID-19 vaccine. There are many doctors in St. Vincent who spent 5 to 7 years in medical school who feel inadequate to recommend or discourage patients from taking a COVID-19 vaccine. What does that do? It reduces the confidence that people have in this medical profession. And the reason for it is because of the failure to to access continuing medical education, which is as accessible now over the internet. There was a time when you had to visit a university for a symposium or for an event put on by the medical association or something in order to hear from experts about new standards and new guidelines for managing a disease condition. Those guidelines are available from professional sources through the internet. And so there is no excuse for a health worker not to avail themselves of this information. They should be able to determine what is a credible source. If a mechanic who went to school in the 1960s when you had carburetor cars only is faced with fixing one of our new vehicles that have electronic fuel injection and computer boxes and all sorts of sensors and so on. How does that mechanic get up to date? In some cases, some of our mechanics have been able to travel to Japan and to other countries and get professional training. But in many cases, some persons have been able to take online courses and have been able to update themselves and get the necessary equipment and operate professionally to be aware of what's happening with these new vehicles. So the fact that something is new should not reduce your level of confidence, but it is up to that professional to decide how important it is to them in order that they are in a position to help their patient. It's the outcome that we're going to look at. And we're going to say, at the end of this talk, after I have spent this time trying to address this issue, the question is, what is the outcome going to be? Because as a healthcare professional, I am interested in a better outcome for people. I want there to be a better outcome for the Vincentian population. I want there to be a better outcome for the health of many people in St. Vincent and the Grenadines. I am saying that if there was evidence that vaccination provided a worse outcome than no vaccination, I, as a professional, would not cover that to say that vaccinations are still safe. But the fact is, the observable fact from all around the world is that vaccinations make a difference for COVID-19. It makes a difference in outcome. It makes a difference in severity. It makes a difference in access to resources, and it makes a difference in us going back to school. There is no question about whether or not this makes a difference. We're not saying that there is zero risk. The risk should be discussed with your healthcare provider. The risk should be discussed with a knowledgeable healthcare provider. And one of the questions you should ask, and a healthcare provider should be honest in answering, is, do you feel comfortable in assessing my risk for taking a vaccine? Because there are guidelines, there are guidelines for assessing risk for vaccination. It is very clear that persons who have an increased risk for blood clotting disorders may need to have a delay until that risk is addressed. Persons who have autoimmune diseases like systemic lupus, which we call lupus, and people with rheumatoid arthritis, and people with kidney transplant, and people with other diseases, there is an appropriate time and condition under which that person can receive a vaccine. And it is not always expedient for a person to be vaccinated on the fly. And so a healthcare provider, a healthcare professional should be in a position to answer many of these questions where data is available, where there is an adequate recommendation that is made regarding this issue. So please, I want to proceed now to answering some of the questions, and I don't know if the moderator has any particular concerns at this time. I want to thank you for participating in the poll. I would like you to save the results, send the results to me if possible. But I think it is really important to understand where we are at this time. So I want to proceed to answering some of the questions.
Yes, Dr. Nedd, go ahead.
Okay. So I noticed that there were some comments earlier and in the chat, and the concern was about why we should be having discussions about vaccines among teachers, because this issue has been so contentious in the past. Education is always important at any stage. I spoke and counseled a client who came in to see me some time ago, a lady in her 60s who took the AstraZeneca vaccine in February and completed her second dose somewhere around May. She said that she was, as a family member, she was included in a family chat where one of her nieces had set up the chat and invited several family members to participate. And she posted when she had completed her vaccination that she'd taken her vaccine, just to inform other people in the family chat that she had been vaccinated. And she received a message subsequently from the person who organized the chat, the administrator of the chat, to say that she never knew that they had stupid people like that in the family. And if she is so ignorant to go and get a vaccine for COVID, she don't want to be in the family. And with that, she was blocked and discommunicated from the family chat. This is something that is happening, and people are feeling like to have a conversation about vaccination, risk versus benefit, mandatory versus not mandatory. What is wrong with having a conversation and education and allowing people to make a decision based on how they understand the information? The important thing is that a lot of people have been exposed to contradicting views and actually need to hear from a practicing professional what it is that we are seeing and what it is that why are we making these recommendations? How does something become a strong medical recommendation? It is not just because of observations made by one individual, but I explained the process of randomized and controlled trials, which help to remove biases from studies. And so it is important for us to understand that when we say something is scientifically proven, that there is no question about a particular observation that is noted. For example, there is no question about the benefit of vaccination in reducing the severity of COVID-19. However, we are never to say that there is no risk in COVID-19 vaccines. We still don't know if there is a possibility of a long-term risk, because nobody has taken COVID-19 vaccines for more than a year and a half. But however, we have experience with similar vaccines, and we know that vaccines of this kind have been used since 2003, 2004 for SARS and MERS. In fact, the US military has been using mRNA vaccines to protect soldiers going into Middle East wars against Middle East respiratory syndrome caused by MERS virus, MERS CoV. And so there is an understanding of the technology and what it is able to do. Vaccines on the whole are generally safe, but they do stimulate your immune system, and they do provoke an inflammatory response within the human body, which can tip a person over if they are in an unstable health condition. The important thing is prior vaccination, a person needs to have an understanding of whether their health is unstable or stable. And in the case of an unstable health condition, can it be made stable, or is this person fit for exemption from vaccination? I think that quite clearly explains the situation that we're in. So as far as the actual questions about vaccination, somebody said that they've been traveling in and out of Trinidad and they've never been able to ask to show proof of yellow fever vaccination. Well, I don't know how long ago that person traveled. Of course, now, in order to enter Trinidad, you would have to show proof of COVID-19 vaccination. So if you think yellow fever was an issue, you may not be going back to Trinidad unless you're vaccinated against COVID-19 until that changes. So somebody said, I heard that persons who take the vaccine cannot donate blood. Is this true? If it is true, how long would it take before they can do so again? The people who manage blood banks generally would have some concerns about the persons who are donating, and there is a time frame for any person to donate blood after having certain medical interventions, medication, and vaccines. The reason for that is because after a vaccination, the inflammatory reaction which leads to your immune response increases the rate of production of what we call acute phase proteins and substances which are released, which are inflammatory into the bloodstream. histamines, leukotrienes, and so on. And so these substances can actually stimulate some inflammatory response in a patient. Therefore, if you have just been vaccinated, it takes about 2 weeks for this reaction to settle. At this point, the spike proteins are gone, and it is okay for persons to donate blood at least 2 weeks after they've been vaccinated against COVID. But this recommendation may vary from place to place. However, at this current time, I am aware that the blood bank in St. Vincent is allowing persons to donate blood after they have been vaccinated. I'm not sure of the exact protocol, how many weeks after, but you can donate blood after you have been vaccinated. Another issue with regards to post-vaccine donations, many of the persons who are listening have heard about antibody harvesting for serum. So persons who have had COVID, their bodies may make antibodies, and in the early years, in the early stages of this illness, some persons were testing whether serum from previously infected persons could be used to treat very ill persons. Donald Trump was recipient of convalescent serum when he became ill with COVID-19. Many of us may not have access to that kind of treatment. In St. Vincent, we do not generally have the access to the procedure to separate and concentrate the serum from convalescent patients to use it so that their antibodies would get into our body to protect us. It's a transfusion. So convalescent serum is the taking of blood from a person who was either previously infected or had been vaccinated, and taking that blood to concentrate the antibodies and to use those antibodies to help somebody who was not vaccinated to overcome COVID-19. The treatment is not 100% up to now. It is not very clear that it is anywhere near as effective as vaccination in reducing the risk of COVID-19 or the severity. Okay. So somebody said they heard that natural immunity is a lot better than that gained by the vaccine. And I think we tried to answer that earlier. Natural immunity, in this case, the person is referring to if you got COVID-19 and you recovered, meaning that your body was able to fight it off in the space of time, and you recovered, that you are now protected against future infection. But you've already had it once. And the risk of first-time COVID is pretty high. If there is a chance that 2 persons out of 100 persons who become infected with COVID without vaccination, 2 out of 100 persons may die. Especially with this Delta variant, it may even be higher. In some studies, 5 persons out of 100 may die. If with Delta variant, based on your population, based on how healthy people are in the immune system and so on, you're willing to take a chance that you might recover. Yes, you might be in the 95% of persons who recover, but the 95% of persons who recover may not necessarily live a normal life after that, because there are other effects that COVID-19 could have in your body that can affect your health and your future. So, are you willing to take a chance, not just in recovering from COVID, but how convinced or how certain are you that if you got COVID and recovered, that you will still maintain your current health status? It is a serious question because many patients who are recovering from COVID or who have recovered are facing symptoms of long COVID. The most common symptom being chronic fatigue, where persons feel that after 6 months after recovering from COVID, there is still this heavy tiredness that comes over them. And some persons are having arrhythmias, and persons are having breathing issues, and some persons have suffered from strokes and blood clots and damage to kidneys and damage to their eyes. I mean, the burden of disease is a lot more than the issue of deaths. And so we really shouldn't be talking only about deaths from COVID-19. We should be talking about this disease as a scourge in our community and something that is threatening to change our way of life, and in serious ways, because it's affecting us not just physically as a health issue, but emotionally, spiritually, and economically. This is something that I would really like to see the end of. And the question is, why is it in St. Vincent that we can't navigate a course out of this illness as we are seeing in countries where vaccination rate has been very high? In the state of Israel, when you look at the current news and so on, you see people moving around as in pre-pandemic times. It is not that they don't have cases, but they have learned to live with it, and they have learned to understand how to reduce the risk associated with COVID-19. And so the people who are likely to die from COVID-19 in that setting are persons whose immune system are quite weak. They have not been able to overcome the illness, even with the additional benefit of vaccination. So if a person has HIV and contracted the COVID-19 vaccine and as a result died due to the previous compromised immune system, what would be the cause of death by the doctor? Well, we did conduct training in St. Vincent some years ago on the writing of death certificates. And for those of you who might be familiar with death certificate, there are several layers that are included in determining cause of death. The first condition is the immediate condition that led to the death. And then secondary conditions which are underlying that may have contributed are also included on the death certificate. And so if a person came in with COVID-19 and had a heart attack, it is likely that the person's death certificate will show that the person died from a heart attack, which was likely precipitated by a COVID-19 infection, and that other underlying conditions like ischemic heart disease was also active in the cause of death. And so the multiple layers for writing death certificate allows you to specify what a person died of. Some people are saying, well, too many of the deaths that are reported are bogus because the person had COVID-19, yes, but maybe the illness and the fever caused them to die from a heart attack in the same way that somebody else with a fever may die from a heart attack. So I ask you, if a person took the vaccine and they got a fever and the fever overwhelmed them and caused them to die of a heart attack, is it the vaccine that killed them? In the same way, if a person got COVID-19 and they got a fever and they got blockage of their blood vessels and they died of a heart attack, is it COVID-19 that killed them? Well, the decision is made based on what there's evidence to support. If it is supported that this person had a fever leading up to their death after vaccination, then it's really the effects of the vaccine that was the condition that immediately caused death, but that the underlying conditions were still active. Now, why this question was asked? Somebody most likely had in mind that perhaps there is some kind of hanky-panky with the way we report causes of death, but you will often find that in the hospital setting, which is where most people die from COVID-19, a few people will die at home, but most people with COVID-19 may die in a hospital setting. And in that setting, it is likely that the cause of death would be reported as the condition for what that person was admitted. And so the person was admitted with COVID-19 infection, not doing well, experiencing complications, and so the cause of death is likely to be COVID-19 infection, but that there was a mechanism by which that death took place. That would be stated further down on the death certificate. Okay? If someone has low red and white blood cells, would you say that they would be likely the best person to give a COVID-19 vaccine? If yes, and why? If no, and why? Low red blood cells, low white blood cells is a condition that we refer to as pancytopenia. It means that your bone marrow may not be producing enough blood, or perhaps there's another reason why that situation may exist. That person obviously needs to be investigated to understand why this is happening, but bearing in mind that if they don't have enough white blood cells, they're also more at risk because they're likely to have a weakened immune system. And so that person may actually benefit more from vaccination if, even though the number is low, their body is still able to produce the necessary immune response. And so people with underlying conditions may benefit even more from vaccination because why? Their bodies are more likely to succumb to the active infection because it may take them a long time to produce an immune response if they became infected. By that time, the virus has already destroyed so much tissue that their survival rate is low. When we look at people who are admitted in hospital with COVID-19 complications, we see, first of all, a preponderance or an increased number of overweight people. Persons who are overweight are more at risk for a severe outcome. Secondly, we see persons with high blood pressure. And there's obvious, clear scientific indication why this is. Both overweight people and persons with high blood pressure have an increased number of ACE receptors, which the virus attaches to and enters cells. And the increase in number of ACE receptors is directly related to the severity of the disease and outcome. So persons with high blood pressure and persons who are obese, it is more important for those persons to have a vaccine against COVID-19. New technology for vaccines is another question. If it's a new technology, it's a new technology and should not be termed a vaccine. It is a risk taking it, and from research, it is not good. Vaccines have been around for many, many years. The first vaccines that were given were actually fluid that was aspirated or pulled out with needle and syringe from blisters on a cow with cowpox and injected into people because the antibodies that were produced against cowpox in humans were protective against smallpox. Those were the early vaccines. Just drawing out some stuff from a cow, injecting it into a human being, because that liquid contained the cowpox, and the cowpox didn't make people as sick as smallpox did, and smallpox carried a very high mortality rate. And so, even though there was a risk from injecting cowpox into some people, it was found generally that those people produced antibodies to cowpox that also worked against smallpox and protected people. Over time, that technology was refined. We no longer stick a cow and pull cowpox out to make a vaccine. Nowhere in the world is that practice still continued in vaccination. And therefore, technology is going to change. How is it that when the technology in your phone changes, that there's not a hue and cry? We have to find ways to get things done in a quicker time, but safely also. And so the understanding of mRNA vaccines is something that has been attempted over many years. We've already had 2 decades of mRNA vaccines for other diseases, but not on a large scale and certainly not on a global scale. But I want you to understand that it is important that this medical and scientific community must come up with ways in which to respond to a public health emergency quickly and to be able to produce something that is working and found to be safe enough. Somebody is very disappointed that I am talking about vaccination, and I believe that their concern is that there are people who have made a decision against vaccination as an option. I don't think that whether we had education or no education, that those persons would change their position. And I still believe that persons are entitled to their own opinion, but not to their own facts. And so if we want to share the facts with people and let people make a decision, then I absolutely see nothing wrong with that. Somebody asked me if I know anybody who got the COVID-19 vaccine and died, meaning probably the same question I asked in the poll about persons who died within 2 weeks of taking the vaccine. Well, At my office, we've been giving vaccines against COVID-19. And one of the things that we ask persons to do is to report any ill outcome, any prolonged sickness. Yes, we expect people to have a slight fever, chills, first in some cases, and we ask people to report side effects, including unusual things that could have happened as a result of vaccination. I am not personally aware of anybody who we have given a vaccine to who have passed away within 2 weeks of taking the vaccine. I don't know of anybody at my clinic who died after vaccination. We have not seen any immediate reactions. We have an observation period. I have not seen any reports in the patients who we've offered vaccination to. But we've had patients who we did not offer vaccination to, who we told now is not the time for you to have this vaccine, even though they came asking for it. And because it is our procedure to perform an evaluation of a person's health before offering the vaccine. So we have actually asked people to defer the vaccine and to come back at a time when they are in a more stable condition to have it. And in most cases, most of those patients have come back in later and taken the vaccine. Jeff said that we need to address the issue that is plaguing vaccine hesitancy, fear. Well, fear is a real thing, and fear and anxiety can lead to more caution, a more cautious approach. And I don't want to say that anybody should not experience fear when you look at circumstances around you. I think it is far more fearful to look at my neighbor who came to see me on a Monday complaining of shortness of breath. At my office, came to see me, and I wanted a better outcome for him. He said to me that, I haven't been coming to see you because I don't get sick. He said, I don't even catch the cold or flu. But this cold I have a hold on me and it's not letting go. And I had it for a whole week. And now it's getting worse. I can hardly walk. Today I couldn't help my family to do anything. That was something to listen to, because when I examined him, he had fluid in both lungs and he had an oxygen saturation level of 85%, and he could not move himself around freely. And this is a big, strapping, muscular guy. I was sad. I kept on checking on him during his course in hospital. And I was told at one point that he looked as if he was coming around. And then I found out 5 days later that he had passed from COVID-19 pneumonia. And if you understand what is happening with patients who are suffering from COVID-19 and people who have been through it at home, even persons who recover, tell you they didn't think they were going to make it because they couldn't eat. I met a gentleman who had already taken 1 dose of a vaccine when he became infected. And he said that he tried to drink an Ensure, and it took him a whole day to get through an Ensure while he was suffering from COVID-19 pneumonia. He has since recovered and he's feeling low energy, but he is looking forward to taking his second vaccine. We don't have to see people who are crying about their loved ones in order to understand why it is an important addition to reducing the burden of this disease. Somebody was talking about what percentage of unvaccinated Vincentians have died because of COVID-19. We're still, I think, in the early stages of this pandemic. I don't think the majority of Vincentians have become infected with COVID-19 yet. The numbers of infected persons is still increasing. We should not always be looking at data released by testing, especially if there are issues related to testing. We knew that in the last 2 weeks that some of our samples from St. Vincent had to be sent off to CARFA for a PCR test. What does that tell you? That there was actually a challenge related to testing in St. Vincent during that period, and that the pickup rate would have been reduced, and that the number of persons who were tested, including persons coming in at the airport, was also reduced because of a challenge with testing. But that doesn't mean that the virus listened or paid attention to what the numbers were saying. The virus is still passing around, because guess what? People who are tested positive for COVID-19 don't always do the right thing. A person called several days ago to ask for an appointment for someone who was displaying symptoms of COVID. The person called back to cancel the appointment because that individual had gone to another flu clinic and was tested positive, instructed to go home. And the person was saying, well, I expect that, they would comply with that order. I stopped at the supermarket that night to pick up some dog food. And the person who was cashing at the supermarket desk ahead of me was the individual who tested positive earlier that day. We know that there are many persons who have tested positive for COVID-19 who are either in denial or they think that they have good enough reason to be still moving about in the population. And I believe that we have not seen the peak of this infection yet. That is my personal opinion. Other people may be looking at numbers and saying that maybe they think we're peaking, but I don't believe that we've seen the peak. And what percentage of persons who've taken the COVID-19 vaccine who have died as a result of the vaccine? Well, this one is really hard to say because I don't know what is the method of testing whether a person died as a result of COVID-19 vaccine. It is possible that there are persons, but I think it comes from the history, and the doctor who is examining the death must understand the course that took place between the person's state of health prior to vaccination and after vaccination and leading up to the death. So it is possible that some persons have died after COVID-19 vaccine. Whether it's a result of the vaccine or not is a decision for a coroner's investigation. Somebody's asking if vaccine is the only protection in the classrooms. I'm definitely not. We would still expect vaccinated persons in the classroom to practice the primary prevention strategy. Every vaccine that exists in our arsenal to treat diseases, every single vaccines, mumps vaccines, measles vaccines, all vaccines they work by introducing the body to a fragment of a disease or a disease-causing germ, and your body recognizes it and produces antibodies in an immune response against it. And apart from producing antibodies, your body is capable of producing a clone of white blood cells that are specialized in fighting that disease. That is the long-term protection. So the antibodies is the short-term protection, and the clone of cells, which are T cells, memory T cells, and B cells, which are specialized in fighting that particular illness, that's the long-term protection. Now, when a person is vaccinated, the long-term protection is stronger than in a person who has had one bout of the illness. Yes, after a bout of the illness, your body produces antibodies, and then with time, the antibodies will fade. After vaccination, the antibodies will also fade. But what is different with vaccination is that in a second dose of a vaccine, you stimulate the long-term protection, which is a clone of memory cells, which at the drop of a hat can begin producing antibodies again for this particular disease. They are specialized. And therefore, the protection provided by vaccination is superior to the protection that is provided by having the illness once. If you got the illness once, then it is still recommended that you take a single dose of a vaccine later on to stimulate the long-term immunity, which is the memory T cells and B cells that are cloned only to produce antibodies against this particular disease. That's immunology 101. And if people still don't understand that, then we can go into it at greater detail, but the long-term protection is much higher with vaccines than without vaccines. Where's the education how to treat family members at home who have tested positive? The treatment of a person who is suffering with COVID is supportive care, as it is for most viral illnesses. In the early stages, we treat the fever, we treat the body aches, we try to improve the appetite, we try to boost the immune system, and things like that. It is really important that some advice should be given to persons after they test positive. I think that in the past has been a failure of the healthcare system. Sometimes persons are just discharged with a positive test, and even the person who is doing the testing is not equipped with the education to tell that individual how to conduct themselves, what to look for, when to come back, how to present. Okay? And so there is adequate information that with most viral illnesses, you really have to wait until your body fights it off and hope that the virus does not cause significant damage by the time your body gets around to it. If you have active antibodies present when you test positive, then those antibodies go directly to fighting the disease, and therefore the control is much sooner, and the viral infection is less severe. There's a question about over 80% asymptomatic. That was with the original COVID-19. Now with Delta, that number has fallen. Far more persons with Delta maybe about 40% of persons might be asymptomatic. But we have in St. Vincent circulation of 3 different variants of COVID-19. We don't have a way of choosing which one we might be exposed to. But if it's the Delta, then the severity is much higher. And so persons who become infected with one of these more virulent variants, the profile of how many persons might be asymptomatic and how many people end up in hospital, that number has changed based on the variants. And indemnity of companies and governments or employers, I am not qualified to speak about that, about whether or not persons who are mandating vaccines should be immune from the potential risks associated with vaccination. Those decisions are generally based on an analysis of risk. When you apply for insurance, the insurance company says, yeah, I will insure this person, but I want a sense of what is the risk to me. If I think this person is high risk, I may not insure them, or perhaps I may insure them at a high premium. Now, when it comes to a government or an employer, I will tell you personally that at the point at which I decided that I would encourage my entire family to be vaccinated, I spoke to our house helper and informed her about the benefits of being vaccinated, about some of the risks of being vaccinated, but I also told her that it was going to be a new condition for working in my house where we don't wear masks every day. Because of the risk of exposure, it was important for me to reduce that risk through vaccination. But it was mostly for her own benefit that I wanted her to be vaccinated. If she became infected with COVID-19, there is still a chance that in contact or being around in my home, that she could pass that infection to me. Or if I became infected, there's a chance I could pass it to her. But because we have significantly reduced the severity, then we might be more willing to put up with that possibility of becoming infected, waiting and expecting that the outcome is likely to be much better. And so it is still a good idea for her, while she is in my employ, to wear a mask. And it is still a good idea for us as a family that when she is present, that we should wear a mask. And it's a good idea for family members to still wear a mask. But the question is, how will families interact? Will we sit around the dining table still and eat, and you can't eat with a mask on? And so we're talking about reducing risk in a significant way, rather than just leaving it to chance. Somebody said ginger tea doesn't deal with everything, and what I'm suggesting that steam and ginger tea and other things do not work. I was not specifically addressing COVID-19 treatment when I mentioned the ginger tea. What I was really talking about is when people access healthcare, If you have a problem, a health issue, at what point do you decide I am going to trust a healthcare provider to help me navigate what might be causing my illness and how to get better? We don't always have the answers. We don't always know what is causing an illness, but we have an approach that includes investigation. And therefore, you are better off if you are really ill, especially when ginger tea is not helping, to go and see a healthcare provider with your illness, because you depend on that professional level of training and that approach that will help you to get to the bottom of your situation. Okay?
Doc.
Right.
Okay, Doc. We we may have to respectfully stop you now.
Yes, I'm okay with that. I don't know if there's any other, I was just going through the chat, but if there's any other pertinent questions there that I don't see anything
Right.
that is different.
We were asking which of the vaccine did you took you and your family, and what was some of the effects that you had. So if you
Okay.
can share with us.
Thank you very much. Vaccines became available in St. Vincent on the 14th, well, to the general public on the 14th of February. I spoke to my family and myself, my wife, my 2 sons, and 2 brothers-in-law took the AstraZeneca vaccine, which was the one that was available at that time. A few of us in the household experienced fatigue. About 12 hours later, I had a low-grade fever and chills. Took paracetamol, and I felt a little bit better the next day, went to work. I worked the first day, but 12 hours later, during the night, I felt the fever and chills, but I took some medicines and I went off to work the following day. I felt run down, really kind of fatigued the next day. And I came home around 5, 6 p.m., had an early night. But by the next day, I was back to my normal self. So by the second day, I felt as usual. Most persons who took any of the vaccines have reported similar experiences, some to a greater degree than others. Some people said they had more fever, and maybe fever lasting 2 days. Some persons reported pain in the arms, in the vaccine site, discomfort or weakness of the arm. I believe that almost 100% of the, well, not, I can't say almost, I know of a few doctors in the hospital who are not vaccinated, and most of them are young. Most of the senior physicians are vaccinated. And I am not aware of anybody who has had any serious outcome as a result of vaccination, apart from the stories that somebody tumbled over and died as a result of the vaccine. I never got a report that one of the patients who were vaccinated suffered a stroke or a heart attack in the immediate aftermath of vaccination. I have not received any such reports, and we have been offering vaccinations without cost to people at Advanced Health who choose. We haven't been forcing anybody or mandating anybody to get vaccinated. It is a healthcare option, and we are concerned. Um, so
Doc,
there's some,
he had
yes,
asked what type of vaccine did you and your family took?
yeah, we got the AstraZeneca vaccine. Now, there is some concern that people have about vaccine choices. Um, at that time, the AstraZeneca was the only one available to us. Even if we had considered taking the Sputnik, it was not available to the general public at that time. Persons choose a vaccine based on data that's available. The studies coming out of Europe seem to suggest that there was some potential for blood clotting events with vector vaccines like Johnson and Johnson, AstraZeneca, and Sputnik. Sputnik vaccine has almost the same design as AstraZeneca. But yet the Sputnik reporting is very limited concerning adverse events. Most of their trials took place in Russia, but they also did some trials in some other countries, I think in Venezuela and so on. I'm not sure what's the quality of the data for Sputnik. One of the issues with regards to Sputnik is that even though it is quite easily proven that people who got the vaccine are producing adequate antibodies against COVID-19, the data regarding safety and the trial data is not easily accessible and was not all made available. And that is the reason why in some jurisdictions they have not considered approving Sputnik for use in their jurisdictions. Even though in the United States they have not approved AstraZeneca for use, they accept that the protection that it offers is adequate, on par or even better in some cases. Certainly shown to be better against the Delta variant than the Pfizer vaccine. The benefit of the Pfizer vaccine is that it uses a smaller dose than even the Moderna vaccine, which is the same technology. Moderna vaccine uses about 100 micrograms of mRNA, whereas the Pfizer vaccine uses about 30. The antibody response is robust, and the course of vaccination is 3 weeks, so that in about a 5-week period, you have a strong antibody protection. The downside is that the antibody levels wane in about 6 or decline in about 6 to 8 months. This is something that has been proven. However, this has not been observed with some of the other vaccines like the Sputnik or the AstraZeneca. And so some people choose that because they don't intend to go back to taking another shot later on. At this time, there is no booster recommendation for AstraZeneca, although persons who are in high risk jobs may take a booster just to make sure that they maintain circulating antibodies. I told you earlier that with a vaccine, the antibody levels will decline, but you hope to maintain vaccine memory through B cells and T cells that have memory for this vaccine. And in the same way, people who are exposed daily, like in ICUs and so on, and people who have higher risk, may still take a booster shot just to keep their antibody levels up after about 6 to 8 months after vaccination. I have not yet taken any booster shot, even though I am exposed to COVID-19 illness on a daily basis. I try to use all the protection that I can get, primary protection, but I may well at some point take a Pfizer shot as a booster.
Okay, okay, Doc. We we want to thank you very much. We really appreciate this very comprehensive presentation that you have made on behalf of the National Executive, the staff, the entire membership of the Teachers Union. We thank you very much for the time that you have spent with us. It was about 3 hours plus. And we appreciate all the information that was put forward. And those of you who were able to receive the information, we hope that you'll be able to use it to make your own decision. The Teachers Union has created this opportunity for you. We are not forcing you to take vaccines, neither are we saying not to take it. It's your choice, it's your body. You have received a lot of information here this evening, well, actually, from the evening to the night. And we hope that you would utilize the information for your benefit, the benefit of yourself and your family and your friends. And as teachers, as you know, we are preparing to go back to the classroom. We ask that you will continue to be safe, observe all the health protocols. The Teachers Union is aware that the Ministry of Education has just sent out a memo. We would be responding to that. I will be having a meeting with the National Executive, and we would be having a meeting with you again to advise you further. So we want to thank Dr. Nedd for spending ample time with us. A lot of research, a lot of references, giving us some actual evidences of his experience in dealing with COVID patients, etc. You may not necessarily agree with everything that he says, and I don't think he's expecting that. So you also you have a right to your own decisions as teachers, but at the end of the day, we have given you the opportunity to make your own informed decision. This activity was planned because we continue to hear members say they need additional information, and we reached out to Dr. Nedd, and he was quite willing and ready to indicate a time and a date. I know those persons who observe the Sabbath, which starts on a Friday. We did say that in our last meeting that you may be at a disadvantage, but we hope that those who are here would be able to share the information for you. So this is the time that Dr. Nedd was available, and we had to make use of the availability of himself to make this presentation to you. And we did promise you that in our last meeting. So Dr. Nedd, we want to encourage you also to continue your great work. We know you are doing an educational drive, and we appreciate you, the time you spent away from your family, spend that time with our teachers here and sharing your expertise. And we look forward that we'll be able to call on you again. Somebody was asking a question, and they might contact your clinic. They're asking if you'd be willing to accept free counseling advice, something to that effect. But I guess that was to reach out to you.
Absolutely, I'm open. Tell them, let them know that I am open. That if they want to come in, we can always have a conversation. I just want to say thanks again. I have utmost respect for teachers. Having been a teacher myself, I think that of all the professions that exist, the one that is most encompassing is the teaching profession. We could not even become physicians or lawyers without persons being willing to teach. It's the way the circle of life continues. We pass on what we know to other generations. And I personally have a responsibility in my community, not just to try to help to look after sick people, but to try to encourage people to maintain their health as much as possible. And so it's not just about the sick and suffering, but also about choices that we make in our daily lives that help to improve our outcome. The it is very clear that longevity, quality of life, um, the amount of years that a person is able to live has expanded over the last 200 years. If you look back from 1800, the average lifespan of a person, to 2000, the average lifespan of a person has significantly increased. And the reason for most of this expansion of people living to be over 100 years old is access to healthcare, scientific advancement. We have people in countries who are surviving their third cancer. I mean, we in this corner here, we don't have access to some of the things, but scientific and medical advancement has been responsible, and we begin to see it as a right um, to be able to access good quality health care. And we have to be understanding that, yes, nobody is going to live forever. But if there is something that you can do to affect the outcome of your life, you have to decide if that is an act of wisdom or not. And so I just hope that the information that I could give could be used in your decision making. We're not the only country in the world. We are not in a vacuum. We should look and learn from other people. We should learn from other people's mistakes as well as their progress. And so I just want us to be willing to understand and to take action when necessary. Thank you.
Okay, thank you. We want to thank our General Secretary, Sister Catherine, for doing the opening prayer. We always put God in everything that we do first. And we also thank her for doing the citation of Dr. Nedd. And for all of you great teachers who are able to stay within this time frame, we appreciate you very much. We thank you for your comments. And we want to wish you good night. God bless you. And remember to observe all the protocols and be safe.
Yeah, my
So,
brother, just finally one thing. I would like to know if you could save um, the poll. If someone can save the poll and maybe forward to me, because I think it is instructive. I think that based on the number of respondents, it is true that there are many persons who don't know that they may have a bias based on information that they've received. But um, I think that that information is very useful as we reflect on it. Thank you.
okay, we want to also thank our technical director, Brother Shedi Conliffe, for his hard work. Yes, the technical director, in collaboration with the General Secretary, would save that presentation and the poll, and we'll have it forwarded to you. Thank you, everyone. Good night. Sleep well and enjoy the rest of the weekend. God bless you.
Thank you. Good night.
Good night, everybody.